Good evening, I'm Benita Zahn, and thanks for joining us tonight for HealthLink. Right now, many of you are being robbed, slowly, and you don't know it. What's being stolen is more precious than gold. It's your sight. The thief, glaucoma. We're going to discuss this eye disease tonight. We're going to talk with people who've suffered the effects and also examine new treatment and research. And we'd like you to join in. You can email us your questions at healthlink@wmht.org. We're going to start tonight with Drs. Albert Morier and Dr. Robert Schultz. Dr. Morier is an optometrist in private practice in Schenectady, and since 1990 he practices twice a week at Albany Medical College, the Lions Eye Institute in Albany, where he's an instructor in clinical ophthalmology in the cornea department. And Dr. Schultz is an ophthalmologist and co-medical director at the Albany TLC Laser Center and at Cornea Consultants of Albany. He's an assistant clinical professor of ophthalmology at the Albany Medical College, Department of Ophthalmology, and has also served as director of the Albany Medical College Eye Clinic. Dr. Schultz is also Associate Medical Director of the Lions Eye Bank at Albany and sits on the National Accreditation Committee of the Eye Bank Association of America. And I was probably bound to add an extra syllable to one of those titles. See, we don't pay you guys for coming in, so you just get the big introduction. But you know, maybe your mom's watching.
Yeah,
you know?
that's good. That's good.
Listen, guys, let me ask about glaucoma, especially as we have an aging population. I want to start. What is it, for starters, and then who's affected?
Well, glaucoma is a disease that does rob sight, and it's silent. It is a disease where the optic nerve kind of is dying. It's an optic neuropathy. And we all think of the pressure being high, and that was the glaucoma test. And frankly, when I came out of school in 1982, that was the standard thought. Under 21, you're fine. Over 21, you're suspicious.
And we're not talking your age, it's the pressure in the eye.
Exactly, pressure in the eye. And since then we found out that that's not true. It's actually a condition where the pressure in the eye is higher than your eye can tolerate. So if your pressure is 15, the national average, but your eye can only tolerate a pressure of 12, then you have problems. You can have a pressure of 28, which is certainly higher than the national average. However, you could be normal because your optic nerve can tolerate that pressure. So it's much trickier than it appears.
Do we understand, one, why the pressure increases? And then two, why some people can tolerate more?
The reason the pressure increases basically is because more fluid is being made than can exit the eye. Over the course of time, your production of aqueous or fluid in the eye decreases, as well as the outflow from the eye. But because of all the pigments and different bodily tissues or cells floating around the eye, the drain work eventually gets plugged up. So the spigot is turned on and there's less outflow and the pressure within the eye builds.
Is this strictly a function of age, or can it be the function of something else?
Systemic drugs, steroids for example, can cause it artificially. Certain conditions, systemic conditions can make it go faster, such as people with diabetes or hypertension may be more prone to it. Even refractive errors, people who are highly nearsighted because of the anatomy of the eye, that can cause increase.
Another big one I would mention would be a trauma to the eye. A severe blow to the eye can really rupture and damage that drain work. It may be that for 10 or 20 years, the pressure within the eye continues to measure normal, and all of a sudden you're 45 years old, you barely remember some injury that you suffered as a child, and lo and behold, you have this terrible glaucoma that needs to be dealt with.
Now, there's more than one type of glaucoma.
Correct.
The most common is that primary open-angle glaucoma?
That's correct.
And is that what you're describing here, this pressure that's building in the eye and not enough drainage?
Correct, yes.
Well, bottom line, based on the anatomy of the eye, the anatomy determines how much fluid is going to leave. Open-angle glaucoma implies that the drain work of the eye itself is completely exposed to the fluid, but the meshwork itself is plugged. Narrow-angle glaucoma implies that actually the iris bows forward over top and closes the drain work up.
But then the pressure shoots up very quickly, and vision can be lost in a matter of hours, and it's quite painful. Just recently, a patient came in for a routine eye exam, and noticed that his angle was, in the routine eye exam, that was very narrow, and referred the patient to Dr. Ghanem, who's here tonight, and Dr. Ghanem agreed that this gentleman is occludable, and is going to be doing a laser procedure to make this, to fix it.
So that's one kind of treatment. Everybody hears about, you know, if you've got glaucoma, you're using drops. What are the, it sounds to me, if you've already got too much fluid in there, why do you want to add more?
You're adding fluid to the surface of the eye, and the purpose of those drops is to shut off the spigot, or at least to slow it down, so that your drain work is then able to keep up with the amount of fluid being created.
Now, the bottom line, though, is there is no cure for this.
No, it's a management. It's a management over time.
And the importance of catching it early?
Well, consider your optic nerve. We have 1.1, 1.2 million nerve fibers leaving the optic nerve, and over time they're dying. And you can lose probably 50% of the nerves before you start having spots in your vision, blind spots, and you won't notice a few of them here or there. But over time, they're decreasing. So it's like a fuse burning. The quicker you stop the fuse from burning, the more you have left.
And that means annual eye exams.
Well, annual or 2 years, depending on the age, your race. Certain races are more prone to it. Family history is very important, risk factors.
We'll get into some of those areas. We're going to bring some glaucoma patients into our kitchen cabinet. But first, take this short quiz on glaucoma. So what is it like when glaucoma begins robbing your vision? What changes, if any, do you experience? And then how do you cope with the diagnosis? For those answers, we turn now to Nancy Fisher and Chris Keller. Nancy's been diagnosed with open-angle glaucoma, and Chris, well, he'd always been nearsighted. But one morning in August of 2002, he woke up, his vision was blurry, even with your glasses on, Chris, and what happened?
Well, I could see out of my left eye okay, but my right eye was very, very, very blurry, and I said, why did this happen? And I sort of ignored it, then I decided to call up and say I'm losing some vision, and sure enough, Dr. Morier I saw. And,
how long did you wait before you made that phone call?
Probably about a week and a half.
You just kept thinking it was going to go away.
Well, I wasn't actually so aware of it because it wasn't, I could see well with the one eye, so it compensated. So I say, well, don't know why this is. Maybe my prescriptions are getting a little bit weak because I hadn't seen a doctor for a while. And shame on me, I should have done a little sooner.
Well, we're going to take the blame away here. This is about warning others, okay?
Okay.
What happened with you, Nancy?
I had a lot of annoyance in my eyes. I didn't know what it was. I thought maybe it was from the computer that I work on.
Mm-hmm. What do you mean annoyance?
Well, my eyes didn't feel right. And they just annoyed me. I kept rubbing them, and of course this made my eyes very red. Mm-hmm. And I decided to go over to the Lion's Eye, and when I did, for my checkup, I found that the pressure was very high in my eyes.
When the doc said to you, I think it's glaucoma,
He didn't say that. He was wonderful.
But at some point, you got that diagnosis.
Yes, that's true, I did.
And your response?
Was we'll fight it, and I was very happy to take all his advice, read up on it. I have booklets at home, and then decided to have my eyes done.
You had some laser
Yes, I did.
procedure done.
Yes, I did.
What
January.
What'd they do for you?
Everything.
Yeah.
They made me feel better. My eyes never got red anymore, and I didn't have to take drops in my eyes because before I had this, it was like 2 years I was taking drops for that. Now I take nothing.
Now, the laser does what? Does it open the unplugging?
Well,
Or I'll do the unplugging, I should say. Yeah.
this is a new laser. It's an SLT laser that Dr. Gundam has, and it's more of a low-energy laser, which, like Dr. Schultz was talking about, the mesh work, this will shoot the laser, make a small hole through to increase the drainage.
Now, it's not a cure, though, right, Nancy?
No.
So you go back and you see the doc how often?
Every 3 months.
It's close management.
Yes.
Chris, let me ask, how often were you going for eye exams?
Prior to that, probably maybe every 5 years.
Let a little time go by.
Yes, I did.
The take-home here is you really do need to go every 2 years or at least every year and get your eyes checked. Did you have any family history of glaucoma?
I'm not really aware of it so much as there being a history of that in my family. There might have been, but I'm not aware of it.
Yeah. What happened after you got the diagnosis?
Well, I also had another problem with my eye, which was more acute. I had a retinal vein occlusion. Was that which is why it went
So bad, so fast.
so bad so fast,
Yeah.
as opposed to the glaucoma. The glaucoma being something that's, now that I have just one good eye, we're going to work on that and make sure that we keep that pressure very low.
So in some bizarre kind of way, having this acute problem actually became the tip-off that you were in the process of developing another problem.
Correct. That is correct.
You know,
yes.
What do you do now, both of you, in terms of, I know, Nancy, you said you're going every 3 months. Is there anything else that you feel you should be doing or you can do to try to maximize the sight that you still have?
You try to be a little more aware of what you're doing, and in my case, I try to protect that eye a little bit more and be aware of seeing the doctors regularly, and I do take the drops, and I take the drops quite, without fail, I take
What's your vision like? And I'm going to start with you, Nancy. Did you see differently? Does
Clearer.
what you see, no, before you were treated, what did the world look like to you when you had glaucoma versus now?
Well, a little grayer, I would say. And as I said, I kept getting all of this redness in my eyes.
Yeah.
And
So-
now I do not.
So there's more color back
And
in
I
the
was
world.
right, and I wasn't wearing any eye makeup, which I can wear now. And all of those little things are thrilling to me.
The niceties in life.
Yes, wonderful little things.
Yeah. What about you? Did you also, was the light world
I think
a
the
little gray?
glaucoma was, like he says, the silent procedure. I didn't know I had it. And possibly, we don't know this, but possibly had it been treated sooner, maybe I would have even prevented
The other problem.
the other problem.
Well, while there is no cure for glaucoma, there is plenty of research going on and new treatment, lasers, as we're talking about. We're going to be talking about all that right after this break, and you may find some of these glaucoma facts important for you. So what are researchers looking for when it comes to a better treatment or even a cure for glaucoma? Dr. Sai Gandham knows. He's directed the glaucoma service since he joined the full-time faculty of the Albany Medical Center in 1997. He's been there ever since. You've published extensively. It's good to have you with us. We've been talking about this laser. Is that the hottest thing right now when it comes to treating glaucoma?
It is. It is one of the latest advances in the treatment of glaucoma. It's called cold laser. Actually, the term is called SLT. And to describe it's called a selective laser trabeculoplasty. What it does is the cold laser, it will selectively, you can just treat the pigmented cells in the meshwork. That's in the drainage angle. So the difference between the previous laser and the new laser is the previous laser called ALT, called argon laser. It damages the tissue much more than the SLT. And the second advantage is if the pressure's gone up after a few years, you can always repeat with different kind of laser.
Is this appropriate for everybody who has glaucoma?
It is a treatment for open-angle glaucoma, primary open-angle glaucomas, and certain secondary glaucomas.
Well, then does this mean that patients like Nancy,
Yes.
if they get the diagnosis, they never have to use the drops, they just go right to laser?
If the patient, we give the options of if they want to treat the medications, or some patients they like to go for laser directly. They don't want to take medications. And the laser advantage is medications can have a lot of side effects. They have to use every day, or twice a day, or 3 times a day. And whereas the laser is once you treat, and if it really works, you don't need to take medications.
No side effects from the laser, no potential problems?
And actually, when we explain to the patient that 3 out of 4 patients, probably around 70 to 80% respond, and the most significant side effect is some patients don't respond. And but during the procedure for 1 or 2 weeks, some patients will have light sensitivity, and some will have some transient redness, etc.
Are there any other health issues that might prevent you from having the laser treatment? Say